Next up, we have the latest in hospice care with Dr. Barry Kinzbrunner of VITAS. And how have the views on hospice care utilization changed over the years?
Well, I think hospice has become much more accepted as a legitimate form of care for people who are nearing the end of life. When I started in 1984 as an oncologist, of course, hospice was primarily looked upon as end-of-life care for cancer patients. It was not very highly accepted even by my colleagues. In fact, I remember when I moved into this field full-time in 1992, my ex-partner, who I had a very good relationship with, was looking for an associate to replace me and contacted one of his good friends in a major cancer center who, when he told him what I was doing, his only comment was, "What is he doing that for?" So it was not highly accepted among oncologists. I think it's become much more accepted in the oncology community today. And also, hospice has now branched out outside of oncology, and we're now caring for many patients with non-cancer diseases, such that now over 60% of patients admitted to hospices are admitted with diseases other than cancer.
What percentage of the overall population does use hospice as a choice?
About 40% of people who die in America today die in a hospice program. I think it's about 2.5 million people die in this country every year, and about 950,000 roughly die on a hospice. Actually, in 2008 there were about 1.45 million people served by hospice, but about 950,000 died.
Why isn't that number higher?
A variety of factors. I think it includes, there is still a significant percentage of the population that does not want hospice services because they want to continue to receive what I like to refer to as disease-directed therapy up until the time they die. In some cases, their physicians are reluctant to talk to them about it. In other cases, the patients don't want to hear about it. I think the bigger issue is even for the people who are receiving hospice, that 950,000, half of them are only being cared for by hospice for about 3 weeks or less. And the average length of stay, the average time that people spend on hospice is about 70 to 75 days.
When should that discussion really take place between a patient and a doctor in terms of what kind of care that patient should be considering?
It probably should start long before the patient's at the point when they really need end-of-life care services. Sometime during the course of treatment even of the illness, especially if it's a chronic illness where cure is not anticipated at some point, it would be important for physicians and patients to discuss what we might call advanced care planning, which would be the election and creation of an advanced directives and the ability to think about, well, what kind of care would I want at some point when this illness is clearly not getting better and my condition is starting to deteriorate, and where it's unlikely for therapy to reverse that. You want to have the conversation before you get to that point, so when that point comes, everybody's already prepared for that inevitable changeover, in a sense, towards end-of-life care.
During the current discussion about how the healthcare system will be reformed, do you see hospice care being a part of that conversation?
It should be. I mean, and I think it is. I don't think there was much addressed in the current healthcare reform bill, to the best of my knowledge, but I think even before then there were conversations about some adjustment to the payment system to reflect the fact that there's an increasing, although small percentage of patients who are living well beyond what people anticipated the time that they would live under hospice. It's clear that hospice care is beneficial, and for people, some people may even extend life. So how we handle those patients, how we handle the reimbursement for those patients becomes an issue, as there's a small percentage of patients who end up receiving hospice services not for 3 to 6 months, but for 6 to 12 months, even some beyond 12 months. Adjusting the reimbursement to make sure they can still receive that care and keeping the care essentially cost beneficial to the Medicare system as well.
If a person isn't sick or isn't at that point, you think this discussion should take place anyway, as this person is shopping around for care and insurance options?
Oh, I think they should be always looking at, is hospice available in the eventuality that I need it. So whether it's, if you're still looking at a commercial health care plan, whether you're entering the Medicare system, obviously there is a hospice benefit, but certainly on the commercial side, looking at, does my health care plan provide hospice services if, God forbid, I should ever need it at some point, if somebody in my family needs it down the road? Yes.
Dr. Kinzbrunner, anything that I've missed that you think we should discuss right now?
People who need hospice care should have the ability to access it in whatever plan they're on. I think it is very, very important, whether it's private insurance, Medicare, or Medicaid, and that it has to continue to be built into the system.